Good morning, class. For today's session, we are going to talk about aviation, space, and deep sea diving physiology. So I'm Dr. Ana Angelica Macalalad Coswe, and my reference for this lecture is Guyton. So the advances in our technology has enabled us humans to achieve greater heights, literally greater heights. So we've had advances in aviation. We're now able to explore space. Aside from the moon, we've reached the other planets as well. And something as simple as mountain climbing, we've also reached greater heights in terms of altitude. So because of these advances in the ability to reach greater heights, there have been a lot of studies now on how this changes in altitude affect the human body. So in the next couple of slides, we're going to discuss what are the effects of altitude and low gas pressures on the human body. So at sea level, our barometric pressure, or at zero altitude, our barometric pressure is pegged at 760 millimeter mercury. And the corresponding partial pressure of oxygen in the air is 159. As you go high up in altitude, the barometric pressure decreases. And because of this, there is a corresponding decrease also in the partial pressure of oxygen in the air. So the higher the altitude, the lower is the partial pressure of oxygen in the air because there's also less barometric pressure, air pressure. And because of this, there is less oxygen available for use in our body at higher altitudes. And this can result in hypoxia, especially in very high altitudes, such as for example, in the peak of Mount Everest. Okay. So at the alveolar level, at different elevations, the combination of your carbon dioxide plus water vapor results in a dilute oxygen in the alveoli, and this further dilutes your alveolar partial pressure of oxygen. So this table shows us the difference between the acclimatized versus unacclimatized person. So here we see the effects of acute exposure to low atmospheric pressure on alveolar gas concentrations and arterial oxygen saturation. So in this graph, you will see in this column the partial pressure of oxygen in the alveoli. The one here represents the level in acclimatized person, and the one in the parentheses, wait, let me use an arrow. So I hope you see my cursor. So the one here inside the parentheses represents the partial pressure of alveoli in the unacclimatized person. And as you can see, at zero altitude, the level is the same between the two. But as you go higher up in terms of altitude, let's say at 30,000 feet above sea level, the barometric pressure has significantly decreased from 760 to 226. And likewise, the partial pressure of oxygen in the air has also significantly decreased to 47 from 159. So this is just the readily available partial pressure of oxygen for you, So when you go high up, the carbon dioxide also decreases because of the decrease in barometric pressure. So because of that, the partial pressure, the combination of the PCO2 in the alveoli and the reduction in the PO2 in the air, results in a reduction in the partial pressure of oxygen in the alveoli that is available for transport by the blood to the tissues. But in acclimatized persons, they've been in high altitudes for longer periods of time. Their body has adopted by increasing their respiratory rate to about 5 times. So they breathe faster. This is a compensatory mechanism because of the chronic low partial pressure of oxygen available to them. And this increase in respiratory rate increases alveolar ventilation. And because of the increase in alveolar ventilation, the partial pressure of oxygen in the alveoli in acclimatized person is higher compared to unacclimatized persons. That's why they're able to stay in the higher altitudes for longer periods of time. So if you are a person who lives in the sea level area all the time, like for us, most people, no? If we go up 30,000 feet, we will be very oxygen deprived. No? But if you're already acclimatized, you wouldn't be as oxygen deprived as an acclimatized person. So alveolar ventilation increases much more in the acclimatized person than in the unacclimatized person because we've already given the body a chance to compensate. So carbon dioxide and water vapor lower the alveolar oxygen because it dissolves the alveolar oxygen in the lungs. No? Even at high altitude, the water vapor pressure in the alveoli is always 47 millimeters mercury. But the alveolar PCO2, like your oxygen, at sea level, it's 40 millimeter mercury. But at higher altitude, it becomes lower because of the decrease in the partial pressure of air or the barometric pressure. But in the acclimatized person who increases his or her ventilation about 5 times, the PCO2 falls to about 7 because of increased respiration. The increased respiration enables the person to blow off a lot of the CO2. So the CO2 is lower, therefore there's lower there's a lower CO2 lowering activity going on in the alveolar O2. So remember, the CO2 lowers the CO2 and the water vapors lowers the alveolar O2. So in an acclimatized person, since there's lower CO2, there's higher alveolar oxygen also. So what happens if you breathe pure oxygen at high altitudes? How does it affect alveolar PO2? No? So some mountain climbers bring their own PO2 when they go in high altitude. So at sea level, the PCO2 in the alveoli is 40. The PO2 in the alveoli is 104. Remember, the PO2 in the air is 156, but in the alveoli, it's 104. If you check your oxygen saturation, it would be about 97%, 97 to 99%. But if you're breathing pure oxygen, the partial pressure of oxygen in the alveoli rises to 673, and the arterial oxygen saturation will go up to 100%. This is not really very different from this one, no? But when you go higher in terms of altitude, let's say at 30,000 feet, there's lower PCO2, remember, and lower PO2 also in the alveoli. And if you check the arterial oxygen saturation, it will be only 24% in the acclimatized person. And this is dangerously low. You have a hard time breathing already or not. Later on, I'll show you the effects of hypoxia in the brain. But if you breathe pure oxygen, you can actually survive because your PO2 in the alveoli will be 139, even higher when you're just at room air at sea level. So your arterial oxygen saturation would be at 99%. So you still breathe comfortably. Okay. There. So let me illustrate to you the effect of high altitude on arterial oxygen saturation. So normally, as I mentioned earlier, at sea level, the oxygen saturation is about 97%. At about 30,000 feet, no, it's below 50% already. At 10,000 feet, the oxygen saturation will be about 90%. And at 30,000 feet, it's, that's 20,000 feet, your oxygen saturation will be at pegged at 70%. So if you are given or if you are breathing pure oxygen here, no, most of the space in the alveoli becomes occupied by O2. No? The nitrogen is displaced by the pure oxygen. So that's why at 30,000 feet, your oxygen saturation will be at about 99%. So you can still reach the top of Mount Everest, even as long as you're breathing pure oxygen. What is the ceiling when breathing air and when breathing oxygen in an unpressurized airplane? So at which level, no? At which altitude will you really be unable to breathe and have brain hypoxia like this one? So usually it's pegged at about 47, no? 47,000 altitude. So what are the acute effects of hypoxia at 12,000 feet if you're breathing just room air? No, you can experience drowsiness, lassitude, mental and muscle fatigue, sometimes headache, nausea, and sometimes even euphoria. No, when you go higher up at 18,000 feet, no, you would experience twitching or seizures, and at 23,000 feet, you can experience, at the peak of Mount Everest, you can experience coma and death. So if you are not well trained when you go extreme mountain climbing, you can die, okay? So what happens if you try to stay in high altitude areas and become acclimatized later on? So if you stay for prolonged periods of time, weeks to years, being exposed to high altitude, there are fewer deleterious effects. And this occurs because of compensatory mechanisms in the body. There is a great increase in pulmonary ventilation, as I've mentioned earlier. There's also a corresponding increase in the number of the red blood cells. And there is also a corresponding increase in diffusing capacity of the lungs, or DLCO. And there's also neovascularization. There's increased vascularity of the peripheral tissues and increased ability of the tissue cells to use oxygen despite low PO2. So this happens gradually, with chronic exposure to high altitudes as your body slowly compensates for the lower PO2 levels. So how does your increased pulmonary ventilation happen? When you're exposed to low partial pressure of oxygen and you experience hypoxia, this stimulates your peripheral arterial chemoreceptors in your carotid and aortic bodies. And this stimulation results in an increased alveolar ventilation by about 1.6 to 5 times normal after several days. Initially, the increased ventilation will blow off your CO2. And by blowing off your CO2, this will result in respiratory alkalosis. And the alkalosis will now inhibit the brainstem respiratory center, which has the opposite effect of arterial chemoreceptors. After 2 to 5 days, as your body has already tried to acclimatize and adjusts to the increase in altitude, this inhibition in the brainstem fades due to renal compensation. The renal compensation to the respiratory alkalosis. So our kidneys tries to reduce hydrogen ion secretion and increase bicarbonate excretion. And by doing this, it normalizes the pH from alkalotic to normal. And when the pH of the blood goes to normal, it removes the inhibitory effect on the brainstem respiratory system. And this now in turn increases ventilation. I mentioned earlier, there's an increase in RBCs and hemoglobin. And remember that your hypoxia is the principal stimulus for RBC production. The hematocrit can go as high up from the normal 40 to an average of 60, and the hemoglobin from 15 to as high as 20. The blood volume also increases by about 20 to 30%. There's also increased diffusing capacity, and this is because of increased pulmonary capillary blood volume. Because of this increase in lung air volume because of the increased respiration, and there's an increased pulmonary arterial blood pressure because the upper part of the lungs are better perfused. So all of this serves to increase the oxygen delivery into your peripheral tissues. Aside from that, there's also peripheral circulatory system changes as an increase in cardiac output initially, but later on decreases when the hematocrit has already compensated and has increased. There's also increased tissue capillarity, so neovascularization or increased angiogenesis. The cells, they also acclimatize. At the cellular level, the cell mitochondria and the oxidative enzyme systems are slightly more plentiful than in sea level inhabitants. So oxygen is used more effectively in acclimatized person than in the sea level counterparts. That's why some athletes, they train in higher altitude areas because of this, in order to improve their cells' capability of utilizing their oxygen. So I'd like to demonstrate to you the sea level of the mountain dwellers versus sea dwellers. Because of initially at sea level, you see that the quantity of oxygen in the blood rises up to about 47%, but in mountain dwellers, it's much higher. In sea level dwellers, the partial pressure of oxygen in the venous blood is about 80, maybe 86%, but in mountain dwellers, it's much higher. And this is because of greater quantity of hemoglobin. There's also reduced work capacity at high altitudes because hypoxia decreases muscle, including skeletal and cardiac work capacity. And if you decrease work capacity, there is a corresponding, or this is directly proportional with the decrease in the maximum rate of oxygen uptake. So if you are an acclimatized person, because of the hypoxia, your work capacity would be just 50% of your normal. But once you start acclimatizing for about 2 months, your work capacity increases because your body has tried to compensate for the hypoxia. And if you're a native living at 13,200 feet but working at 17,000 feet, your work capacity is even higher. What happens if you ascend or descend rapidly? You can develop acute mountain sickness and high altitude pulmonary edema. So you ascend, this happens when you ascend or descend rapidly. This can happen over hours up to 2 days after ascent. What happens during acute mountain sickness because of high altitude? First, you develop acute cerebral edema. No, there's lots of swelling in the brain, and this is because of our cerebral blood vessels vasodilation, which is precipitated by the acute hypoxia. And because of the acute cerebral edema, these people can develop disorientation and cerebral dysfunction. Aside from that, no, you can also have acute pulmonary edema. There's also swelling in your lungs. No, this is because the pulmonary arterioles try to constrict, no, potentially due to hypoxia. So in the brain, hypoxia triggers vasodilation in an attempt to deliver more oxygen into the brain cells. But in the lungs, the hypoxia triggers pulmonary arterioles to constrict. And pulmonary blood flow is forced through fewer and fewer unconstricted vessels. So the blood cannot flow properly because of the vasoconstriction. And because of this, there's progressive pulmonary edema. There's backup of fluid in the lungs because of this constricted blood vessels. And this could be lethal because you will not be able to breathe. And breathing oxygen can reverse the process within hours. So what if you have chronic mountain sickness? You will experience a sequence of events beginning with increase in RBC mass and hematocrit, which can become exceptionally high. And because of this, your blood will become very viscous, no? And this increases your risk for slowing of the movement of blood. You can also have blockages, you can have stroke, you can have heart attack because of this high viscosity. The pulmonary arterial pressure becomes higher than normal. Because of that, remember the hypoxic vasoconstriction. Because of the vasoconstriction, the pulmonary arterial pressure increases. And because of the high pulmonary arterial pressure, the right side of the heart becomes greatly enlarged. Because of the high pressure in the lungs, the right side of the heart cannot pump to the pulmonary circulation. And because of this can cause right-sided heart failure. And the peripheral arterial pressure falls, and with congestive heart failure, because the right side of the heart cannot pump against a constricted pulmonary system, no? This can result in death unless the person is moved to lower altitude. Okay, let's pause for a while, no, and take a short break from this video, and I'll post the next video tackling aviation and space physiology.